Okay, so welcome to everybody to this month's STRIVE Learning Lab, which is on the structural factors and the HIV prevention and treatment cascades. Sinead Delaney-Moletwe are from WITS Reproductive Health Research Institute, and James Hargreaves from the London School of Hygiene and Tropical Medicine are going to be presenting today. I'm Mitzi Gaffos. I'm a co-research director of STRIVE and have the pleasure of chairing today's session. STRIVE is a research consortium funded by the UK's Department for International Development to tackle the structural drivers of HIV, and the consortium partners in India, Tanzania, South Africa, US and the UK are conducting research into a range of structural factors, including alcohol, transactional sex, gender norms, stigma and violence, and in relation to today's presentation, considering how structural drivers impact on the HIV prevention and treatment cascades. We have another exciting learning lab next month looking at structural drivers in the context of development synergies and the Sustainable Development Goals, so please do look out for that. Many of you will know that all of our learning labs are available on the STRIVE website, along with a range of materials on structural drivers that you can access at any time. And just a final note to say, at the end of this presentation, you will receive an email to complete an evaluation form, and that really is important to our funders, so we appreciate you taking the time to complete that. I'm going to hand over to James, who will start the presentation. They will switch between them. We'll have about 40 minutes of the presentation, and then we'll have the opportunity for a Q&A session. So I'll hand over to you, James.
Great. Okay, thank you. Right, welcome everyone to this learning lab. As Mitzi said, Sinead and I are going to do a tag team this afternoon for the Learning Lab on structural factors and HIV prevention and treatment cascades. Where are we? And we're giving this presentation partly on behalf of one of the working groups on the STRIVE. So here's an outline for what the structure of the talk is going to look like. I'm going to give a brief introduction and kind of cast STRIVE's work in the era of cascades that we all currently work in. And then STRIVE has encouraged each of the working groups to come up with core messages from their work. And what we're going to do after that is that Sinead and I will both speak to one example under these three headings, these three messages about biomedical HIV prevention tools not being able to do it on their own, about our capacity to address structural factors, and then to talk about a couple of innovative new studies of the type that we think are needed going forward, and then Sinead will lead the discussion. Okay, so it's worth remembering that cascades weren't as in the news as they are today when STRIVE started. When STRIVE started, there was, and there remains today though, an unmet need for HIV prevention, both through primary prevention and through treatment as prevention. And that need is particularly unmet in what are widely known as key populations, and that includes adolescent girls and young women in the areas of Southern Africa. When STRIVE started, discussions about HIV prevention had been particularly dominated for some time by discussions about our need to change behaviors. And the growing and wide experience was that behavioral interventions on their own would continue to struggle to achieve the gains in HIV prevention that we needed, not least because structural factors acted as a barrier to them working. And STRIVE was at least partly set up explicitly to respond to this growing realization. But around the time STRIVE started and over the last few years, there have been real advances in knowledge about biomedical prevention, both primary prevention through PrEP and through BMMC, and also about treatment as prevention. And these advances in knowledge of biomedical prevention offer real promise for reducing HIV incidence at a population level. But critically, that will only be achieved if sufficient coverage can be achieved with these tools, and that will be the underlying theme of this talk. I'm assuming most people on the call work in HIV and therefore won't be remotely surprised by seeing a treatment cascade. It dominates much of the discussion in HIV at the moment. This is from a recent BMJ paper trying to achieve a global cascade. And the point of the treatment cascade, as you all know, is to understand and break down the steps necessary to achieve viral suppression amongst people who are living with HIV, both for their own personal health benefit, but also for the impact that will have on the transmission of HIV. And so the treatment cascade breaks down these steps into the need for people living with HIV to be diagnosed with their infection, to be linked and initiated on antiretroviral therapy, and then to be sustained over time on successful antiretroviral therapy so that their viral load is suppressed. A concept that's newer and not as widely talked about, but one that we've worked on during the course of STRIVE has been the prevention cascade. And this was released in a series of papers in Lancet HIV around about the time of the last AIDS conference, and the underlying idea here is very similar to the treatment cascade. The idea of the prevention cascade was to unpick the steps needed to achieve protection from HIV infection amongst people who are negative and could benefit from prevention. And Jeff Garnett's paper in that series produced a load of schematic cascades, and let me just quickly show you through the right-hand side of the ones that you can see on the screen, the intervention-centric prevention cascade. So while the treatment cascade starts with people living with HIV, the prevention cascade starts with a population at risk of HIV, and then it outlines these 3 steps necessary to achieve protection. One is that people have access to and are supplied the products they need to prevent themselves being infected. One is that they have demand for and take up those products. And a third and last one is that they adhere to those products over time. And if those 3 steps can be achieved, similar to the treatment cascade, prevention can be achieved. So STRIVE, in this era of cascades, I think the work of the biomedical working group was driven by 2 main questions. Will structural factors, as they had for behavioral HIV prevention, will structural factors act as barriers to the success of biomedical prevention tools? And if so, how will this come about? Why? And amongst who will this barrier effect be most pronounced? And secondly, can programs address structural factors in order to optimize the impact of biomedical prevention? And so what the remainder of the talk is going to be organized is under 3 messages. I'll talk about one example under each message, and so will Sinead. And the first is this idea that biomedical HIV prevention tools can't do it on their own. And I'm going to start by just talking about some work that we did very early on in STRIVE about the theoretical idea of the inverse equity hypothesis. So this is the simplest representation of that hypothesis. And at the time that we began to think about this idea, what we were mostly interested in was the peculiar phenomenon, or the unexpected phenomenon, that people had seen higher HIV prevalence in higher socioeconomic groups early on in the epidemic. And this hypothesis was useful, at least to me, in thinking about why that might change over time. And the hypothesis basically reads that new interventions, such as, for example, the new biomedical tools that we have for HIV, both primary prevention and treatment prevention, that they will initially reach those of higher economic status, socioeconomic status, and only later will they affect the poor. And this seems particularly important for us to think about as the cascade becomes dominant, and our idea is to try and get coverage with these efficacious tools and how that will happen as they roll out over time. And I'm just going to show you 2 slides before handing over to Sinead that illustrate why this might be something that we thought was happening in the early part of STRIVE. So this is some data from national surveys in Tanzania. It shows HIV prevalence stratified by sex and educational level in 2 national surveys 4 years apart, in 2003 and 2007. And I just want to walk you through this really just to get across that idea of the inverse equity hypothesis. In 2003, you can see, let's concentrate mostly on the females, the pattern is similar in males. In 2003, you can see that HIV prevalence was 5.8% amongst those with no education, and was slightly higher in those with primary, and even slightly higher still in those with secondary education. And as I said earlier, that was a pattern that we saw early on in the epidemic. The thing that we were concerned about here, though, was trying to understand how things have changed over time. And between 2003 and 2007, there was a slight increase in HIV prevalence amongst those with no education, a slight decrease amongst those with primary education, and a stronger decrease amongst those with secondary education. And you can see those changes expressed as a risk difference percent in the bottom row. And the fundamental idea is there are many things underlying prevalence trends here, but to the extent that these changes influence partly what's going on with incidence, they reflect some support for this inverse equity hypothesis, the idea that what gains were being made in prevention would be most strongly realized amongst those from higher socioeconomic groups. And then this is the last slide, just to say that we wanted to, at the beginning of Strive, one of the first pieces of work that we did was to extend that analysis to 7 countries. This is a busy slide, I realise, with lots of graphs on it. We wanted to extend it to 7 countries and to focus particularly on young people, amongst whom the prevalence trends may be reflective more of incidence trends rather than other things such as mortality and migration. And the underlying message here is that it was a bit messier when you do it over multiple countries than in that one Tanzania example. If you can see at the bottom here, Tanzania is reflected in the 5th and 6th graphs along the bottom row. And you can see those lines there. The blue line is for secondary educated people, the green for primary, and the red for uneducated people. Those reflect the pattern I just showed you before, with steep declines in secondary educated and less steep declines in the green and red lines. Across the whole range of countries, there appeared to be a regional effect and somewhat less strong support for this hypothesis as a whole. There are many other explanations that you might underlie these trends, and you can see in the sexual behavior data by education that there was some support for this idea. But I wanted to leave you with the idea that this inverse equity hypothesis provides a useful framework for thinking about why there might be changes in the cascade that differ between socioeconomic groups over time. And with that, I'm going to hand over to Sinead for the next section.
Thanks, James. So now I want to share with you some of the work that the Biomedical Working Group in Strive worked on over the last couple of years. And essentially, Strive has addressed these 4 structural factors. And we are aware that gender inequality has been shown to limit women's choices, and often those choices are at odds with HIV prevention, particularly if male partners are influencing decisions about HIV prevention uptake. We also know that poverty and inequality undermine the capacity of populations to access HIV prevention services, and similarly stigma may also limit people's access to services, but also their adoption of particular safer behaviors. And widespread alcohol use has also sex and potentially increase the risk for HIV, have been shown to influence HIV risk behavior, but we were interested in whether they also had effects on the HIV treatment and prevention cascades. So we conducted a scoping review really to map the existing literature, and we essentially conducted a review of reviews. We used specified mesh terms and keyword searches based on those 4 structural factors, and then looked for terms associated with the HIV treatment and prevention cascade specifically. Those titles and abstracts were then extracted and reviewed by 2 reviewers. And so in total, we identified about 45 reviews, of which 20 ended up being included in our final analysis. And we also attempted to try to map where there might be gaps in the literature, as well as to assess the strength of evidence for each of these structural factors and their influence on the cascade. So I'm going to go through, as an example, what we found in relation to violence and fear of violence, and we'll run much more quickly through the other examples with the idea that hopefully you'll be able to see the overarching pattern. So when we looked at reviews of studies around the influence of violence, be that intimate partner violence or non-partner abuse, what we find is that gender inequality undermines women's decisions around accessing HIV testing. Some reviews, women's fear of partner violence prevented them from actually going to HIV counseling and testing services, although some other studies didn't show any difference by intimate partner violence status, and in one instance, one study actually suggested that experience of violence may motivate HIV testing. So some mixed results there, but also some evidence that fear of violence prevents disclosure. When we looked at the effects of violence on ART initiation, what we found is that intimate partner violence was associated with reduced access to care and treatment in the majority of studies, but not all. That intimate partner violence in a meta-analysis was associated with lower current use of antiretrovirals. And when we looked at studies that reviewed particularly PMT-CT, women were often reluctant to include their male partners because of fear of violence. Then in terms of the last 90 in the treatment cascade, when we looked at the influence of violence on adherence and retention and care, what we find is that intimate partner violence reduced by half adherence to ART. And in one important study, what we see is really some indication that in fact this translates into clinical outcomes. So partner abuse was associated with poor medication adherence, but here they also actually had evidence for poor treatment outcomes. And then some additional studies also showed that intimate partner violence was associated with treatment discontinuation and loss to follow-up. So there is a body of evidence that supports the idea that these social and structural this violence may influence the treatment cascade. Data for prevention cascade, but what we can start to see already from results from trials and from emerging demonstration projects is that these factors are likely also to influence PrEP uptake and use. So the next slide really just summarizes results then for socioeconomic status. I think the point about socioeconomic status was that it was challenging to define on sort of one axis of poverty. And so a lot of the reviews have highlighted sort of measures of socioeconomic status such as transport costs, food shortages, and housing instability as issues that affect either HIV testing or ART initiation or continued use of antiretrovirals and retention in care. And some data, at least from one of the reviews, suggesting that antiretroviral adherence could be improved with provision of food, suggesting that if you intervene on these factors, you can actually also improve HIV treatment outcomes. Again, a lot less data for prevention cascades. So for stigma, the findings are fairly consistent for stigma, that it is a barrier both to uptake of testing and linkage to care as well as retention in care, but fewer data perhaps on clinical outcomes. And again, while there's less evidence again for PrEP programs, although there definitely was reporting in the PrEP trials around this issue of ART stigma and how it may have influenced adherence. And the belief is that the mechanism that, is that stigma is largely has an effect because of fear of disclosure. So when we looked at alcohol, there's also evidence that alcohol impacts on HIV testing and service utilization. And in fact, several reviews identified that it negatively affects all steps of the cascade. But also, again, here we see data that supports that not just the process indicators of the cascade, but actually negative impacts on clinical outcomes and response to treatment. And also that there are worse outcomes in relation to some of the complications associated with antiretroviral therapy. Again, more limited data, very few data available for prevention. So in summary, we could conclude that there is evidence that each of these structural factors influence elements or all of the cascade, that in some cases the evidence is mixed, that the direction may go in both directions. And our feeling is that that may in part be related to how these factors are defined within the literature. There is limited evidence for prevention interventions, for example, PMT-CT, PrEP, and PEP, but what we know from particularly emerging PrEP trials is that the trends appear to be similar. Another important observation from this review was really that, kind of the strength of evidence, there are not that many randomized controlled trials that have tested these hypotheses using interventions, that most of the data is observational, and and several of the reviews that were included were qualitative. And within that, there are also important gaps in sort of describing aspects of the cascade. So, but nevertheless, I think the messages are clear. And the last point really is that while this is indicative, overall there's few data on how some of these findings translate into clinical outcomes, but also population level impacts for programs. So I think the implications are really that as we attempt to expand both, HIV prevention, both in terms of expanding access to treatment, but also access to prevention, that if we want to really optimize the cascade, that first graph that James showed you, we need to think about how we can address these factors. And we need to think about developing programs that are going to optimize those ART benefits, which we know will have a biological effect on HIV, but will not be successful if we don't address the underlying factors that are shaping risk, but also influencing people's use of these technologies. And what we really need in order for programs to be efficient and scalable is to understand what are those factors that are uniquely sensitive within the cascade and which can, through intervention, then optimize the cascade. So I think that as a group at STRIVE, we have been persuaded that structural factors do influence HIV treatment and prevention program outcomes. And so the next question is really, well, can you do anything about these factors? What do we know about interventions to address violence or alcohol? And I just wanted to run very quickly through some of the work that STRIVE partners have been involved in, which have really been aimed at trying to synthesize what works for prevention. And it's important, I think, to emphasize that from an HIV perspective, we know that these antiretrovirals have effects against HIV. We're not looking for interventions that are structural interventions that are necessarily going to have HIV outcomes. But what we want potentially are strong programs that are going to address these structural factors which are clearly influencing the HIV program outcomes. So this is work that was done by some partners in the STRIVE consortium with other collaborators to really review what the evidence says about interventions to prevent violence amongst women and girls. And the evidence was reviewed both from high and low income countries. But I think what's exciting is that there are a number of interventions that have been evaluated in low and middle income countries which show really promising effects within programmatic timeframes, and in fact are being incorporated within some programs at a country level. Those that are promising, in fact, all have common to them a focus on community mobilization, empowerment, and group training, as well as the potential for economic interventions. Point about the economic interventions, we've highlighted earlier on that poverty and socioeconomic status influence the treatment and prevention cascades, and this is a slide that summarizes work that was done in relation to the IMAGE trial, again by STRIVE partners. And the take-home message really from this graph, which shows the effects of microfinance either against a control or the IMAGE intervention, which was microfinance plus a gender empowerment intervention versus the control, and then IMAGE versus microfinance alone. The key message here is that it's the combination of cash with the empowerment that led to the most benefits across a range of both economic as well as empowerment and violence prevention indicators, and importantly had effects on upstream factors behavior. So improving things like communication and condom use may be important, may not on its own be enough to influence HIV incidence, but together with antiretrovirals may be an important intervention. There's also work being done by partners within STRIVE to look at the what evidence there is for addressing stigma, and this is a very important review done by Anne Stangl and colleagues, which show that there are studies of high quality that have evaluated stigma interventions, and that really the evidence is strongest for interventions with students, healthcare workers, and community members, and essentially those that are structural or counseling based are likely to have greatest benefits. Just a word on alcohol to say that the WHO has really recommended a series of best buy policy interventions, and these very much are operating at the policy level. They are evidence-based and are there are indications that they will reduce problem drinking and the effects of problem drinking. So in addition to some work that has been done much more at an individual level, there are interventions that can be delivered at a structural level that may have benefits for alcohol. And so I think the important message from all of these examples is really that there is a burgeoning amount of evidence to support intervention on some of these social and structural factors operating at different levels, from the individual all the way through to a very legislative and sort of national or community level. And what we need to think about now is how to apply some of that knowledge to how we think about HIV programming. So at this point I'm going to hand over to James.
Great, thanks, Sinead. We'll plow on. So the second bit under this heading of can we do anything about these structural interventions, about these structural factors in programming, I thought I'd just share 2 or 3 slides on some of that work, taking that idea of the prevention cascade a bit further, and particularly the work that STRIVE colleagues were involved in. When we started out on the prevention cascade work, the thing that most people thought that framework would be useful for was monitoring, a bit like the treatment cascade and the 90-90-90 goals, that it would be a helpful framework for understanding and monitoring levels of demand for, levels of accessibility, supply of, and levels of adherence to these prevention products. But the take that STRIVE colleagues took in particular was to want to go that next step and to map interventions against those pillars in the cascade. And I want to I really just want to mostly just take you through the thinking rather than the results, although I'm going to show you the results of a big systematic review of reviews. I want to point out that it was quite a radical idea going on here. One of the things that was regularly talked about in this work was the idea that the terminology of biomedical, behavioral, and structural interventions no longer really served us very well, that there was far too much overlap in those things. Biomedical interventions only work if you use them, which is a behavior. Most of the intended outcomes of structural interventions are behavioral. And so this group really wanted to kind of get rid of that, that lexicon. And I just want to walk you through how we thought about and how that maps onto structural interventions on this picture. So on the right-hand side, you can see these are those efficacious prevention behaviors and tools. I want to make the point that we included within these direct mechanisms of HIV prevention, as we call them, primary prevention behaviors that didn't involve technologies such as abstinence or serosorting or partner reduction, but also PrEP and condoms and VMMC. So we call these the direct mechanisms of HIV prevention, and our underlying that cascade idea was that if you could do things to increase the coverage of these things, you would have a prevention impact. And what we wanted to do was map the prevention literature against interventions principally targeting demand for these direct mechanisms, those principally targeting supply, and those principally supporting adherence. And you can see in this, I'll go through the column on the left-hand side in a bit of detail, and then you can fill in the gaps for the other two. But the idea was that drawing on behavioral theory, we identified the various targets for programs that would improve demand for or motivation to use these direct mechanisms. That might include risk perception, awareness and accurate knowledge about the effects of the tools, etc. But these interventions, we have a body of research evidence that tells us about which interventions can respond to these targets as a way of dealing with increasing the use of these prevention products. And then the next two steps were to identify what platforms those interventions could be delivered through, and to think about structural things such as policies that would support the delivery with high coverage and high quality of these interventions through these platforms. And so I hope you can see in that, even in that demand side of the cascade, there's both behavioral and what we think of as structural components, but with the aim of getting these biomedical products used. And we applied that thinking also to interventions on the supply side, what targets are about the accessibility and availability of these interventions. The interventions include some of the things that people call structural interventions, such as mass condom distribution programs, the platforms through which they might be delivered, and the policies that would support those. And finally, perhaps those most close to people in Strive's hearts are these adherence interventions under this framework. These are the things that if you want to use a condom and you have a condom, what are the barriers to actually using a condom? And so that includes capabilities and self-efficacy and agency. The type of interventions that you might consider to improve those things are longitudinal counseling, interventions targeting social determinants, those kinds of things. And then we talk about the platforms and policies through which you might deliver those. So that was the idea of the prevention cascade, was to reshape the HIV prevention literature, both looking backwards and then thinking about going forwards, so that it responded to this prevention cascade. And I'm really not going to talk in a lot of detail, partly for time reasons, but also because it's published, about the review itself. But just to note that what we did then, having adopted that framework, was conduct another systematic review of systematic reviews and identify all of the HIV prevention literature that we could find in the form of systematic reviews, and then map those reviews against this new framework for thinking about how prevention works. So reviews of direct mechanisms of prevention, reviews of interventions principally focused on demand, those principally focused on supply, and those principally focused on adherence or use to the interventions. And in the next slide, this is a table you won't be able to read the numbers of, and as I say, the point wasn't really to get across the results of the review, but to show that what we attempted to do and were successful in doing was mapping out the interventions reflected in those reviews against this new framework, and see the strength of evidence that they had an impact on incidence as well as behavioral factors. Okay, so I'm going to move on, and we can talk about the results of the review if you'd like in the discussion, and talk about the final message. And here we're going to talk about two innovative studies that are trying to improve our understanding and our thoughts about how to respond to structural barriers in HIV prevention. I'm going to talk about stigma and treatment as prevention, and Sinead will talk about empower. I don't think for this audience I need to define stigma, but that's what this slide does. We've been thinking in a study that we're doing, which I'm going to talk about in a second, about how stigma might explicitly interact with treatment as prevention, and particularly the idea of a universal test and treat approach to HIV prevention. And our work is guided by three hypotheses that we want to track. One is that the scale-up of universal test and treat might change, and specifically might reduce levels of HIV-related stigma by making testing and treatment universal, and by increasing people's interaction with people living with HIV and the treatability of the disease, it may reduce stigma. A second hypothesis is that pre-existing HIV stigma might undermine the effectiveness of universal test and treat, or of other treatment as prevention strategies. And the third is that it may change the forms that HIV stigma takes. In the work that we're doing, we want to explicitly reflect that stigma arises out of interactions between different groups of people, sometimes known as us and them in the stigma literature. And our work focuses on collecting data not just from any one of the groups represented on this slide, but from all four of them, and seeing how those the perspectives of these different constituents interacts and produces or challenges stigma. So we collect data in the work I'm going to tell you about from people living with HIV, but also from people living in the communities that those people living with HIV live in, and we hear about the experiences of people living with HIV and about the attitudes and perceptions of the community. We also collect data from health workers, who can be important constituency who both challenge or can uphold stigma, and are a particularly important barrier to the cascade where stigma does exist in health settings. And finally, we think about those vulnerable or key populations, sometimes whose behaviour is stigmatized because of its association with HIV, or because perhaps they practice sexual behaviors that are not socially ascribed. And we, in the work, in the pop-art trial that I'm going to show in a second, we built on work done under the STRIVE banner early on in the consortium on measurement led by my colleague Anne, who Sinead's already referred to. And in particular, the really innovative thing that we've tried to do is adopt this parallel approach to the measurement of stigma, where we used consensus items from all of the years of stigma research that was summarized by Anne. And then we use this parallel approach where we take these memes, like being talked badly about as a manifestation of stigma, and we ask explicitly about that from the perspective of people living with HIV. Have you been talked badly about? From the perspective of the people living in communities, have you ever talked badly about or done so with your colleagues? From the perspective of health workers, have you ever seen your colleagues talking badly about their clients? And also from the perspective of those vulnerable populations, have they been talked badly about, for example, for selling sex, or for men who have sex with men experiencing that gossip? And so we took this idea of a parallel approach to stigma measurement and nested it within a large cluster randomized trial of a universal test and treat intervention. And that's the pop-art study. In IAS last year in Paris, I reported some of the initial findings from that work. The trial finishes over the course of the next year, and the results will be known, and we'll be able to answer our hypotheses. But just to give you two little insights on the work that we've done to date, we're finding confirmation of the importance of stigma in and around health facilities, and lots of interesting information about how the way in which patients flow through facilities and the records that go with them or are attached to them in using facilities are an important determinant of how they feel in accessing those services. We're also uncovering a particularly important and new strand of work on the experience of healthcare workers who themselves are living with HIV, and how that influences both positively and in more challenging ways the way that UTT is being rolled out. We've confirmed or have similar evidence to other work we've done in Zimbabwe, where we showed that sex workers living with HIV will feel considerably more stigmatized because of their involvement in sex work than because of their HIV status. And that's a phenomenon that we think is growing and is present in the communities in this trial, that maybe HIV stigma, a few things in the literature suggest that's reducing, but that persistent stigmatization of some groups defined on the basis of their sexual behavior may be a particularly important barrier to care. And we've got some emerging work from some case control studies nested in the trial, and from our own secondary analyses, which will be reported at the conference in Amsterdam this year, on how stigma influences the uptake of an offer of home-based HIV testing, which is one component of the intervention, and also how it influences linkage to treatment for early ART and adherence to ART once you have started. And the final thing to say from that work, from the baseline work, is that the prevalence of stigma remains high. About 1/3 of the people living with HIV in this very large sample across 2 countries and 21 communities, just over 1/3 of individuals living with HIV reported to us that they'd experienced either stigma in their community, stigma in a health setting, or a feeling of internalized stigma in the last year. And so we're going to track over the remainder of the trial whether this high prevalence of stigma reduces or whether it acts as a real barrier to the rollout of the treatment as prevention intervention in this trial. And with that, I'll hand over the last bit to Sinead.
Thanks, James. So just some brief background to frame Empower, which is a study that was designed to evaluate the feasibility and acceptability of a comprehensive HIV prevention package for adolescent girls and young women in Tanzania and South Africa. Really, the idea was that HIV incidence is very high in these communities, but also levels of violence against women are high in these communities. About 1/3 of young women have lifetime experience of violence. As we've seen, violence influences the treatment cascade, and also there was data emerging from PrEP trials that violence had potentially influenced adherence to PrEP in those trials. As you've seen, there are interventions that have been shown to influence experience of violence and stigma, and most of those are activities that involve community mobilization, as well as group-based participatory activities that focus on empowerment. And in addition, we were aware that WHO has in fact made recommendations around how the health system should respond to violence, and particularly in relation to identifying individuals who experience violence in order to be able to the numerous health outcomes that are associated with experiences of violence. So it was on that basis that we really designed Empower, and that study was really aimed at initially incorporating screening for gender-based violence within HIV counseling and testing processes. So the pre-testing process, where there is a risk assessment, included a risk assessment for violence. And women who were found to be at immediate risk of harm were then linked to services. Those who were HIV positive were also linked to services. And young women who were then identified as HIV negative were offered the option of initiating PrEP. They could choose to decline PrEP, but they were still enrolled in the cohort and randomized empowerment clubs or not, and followed up for up to 15 months. So that's the aim of this, that we have just completed the follow-up of all participants. We enrolled close to 400 young women in the 2 countries. The results should be available we are hoping kind of towards the middle or the latter half of the year. But just a couple of key points for this group. I think because PrEP is a new tech, develop a new set of tools to introduce populations to that technology, but important also was the development of a simple GBV screening tool integrated into HIV counseling and testing, which has proved to be very feasible and acceptable. In terms of the work really around the kind of what we know about violence prevention, we focused on the development of these empowerment clubs, which had a structured curriculum developed, which included 4 modules, which essentially addressed issues around empowerment, disclosure, communication with partners, discussions about sexual and reproductive health, and how to kind of communicate that with partners. And that has been implemented over the life of the project. And another important piece which has come from the violence prevention field and stigma reduction has really been the importance of stakeholder engagement and community dialogues, and the need to generate momentum not just within adolescent girls and young women, but within the communities in which they live, to have discussions about positive or healthy partnerships or aspirations for healthy partnerships, but also how to tackle really the issues of violence and stigma within our communities. So as I mentioned, the study has just completed, and we hope to present results later on this year, but really it's presented as an example. We've taken the work in STRIVE, our understanding of HIV programs, and kind of the potential for new technologies like PrEP, but also how we've attempted to incorporate some of our understanding of what works for prevention of violence in an HIV program, to see whether it's possible to have benefits both on empowerment and stigma reduction, but also benefits for the HIV prevention program. So I hope that we have been able to share with you and persuade you that biomedical interventions are on their own are not going to end AIDS if we don't address the structural factors that are shaping HIV risk, but that are also undermining potentially prevention and treatment programs. We believe that there's evidence that structural factors can be addressed within programmatic timeframes, and that there is a growing body of evidence to support interventions that have been shown to have effect on these factors. But critically now we need to begin to think about how to incorporate this knowledge into programming so that we can come up with more evidence of how to deliver effective interventions that address both the structural factors but are also able to ensure optimal delivery of HIV biomedical prevention programs, and ideally to evaluate these interventions at scale. So that is, I think, essentially it. We acknowledge the contribution of all the partners in the biomedical working group, and happy to take questions or comments or feedback from the audience.
Thank you, Sinead and James, for a really good overview of all the thinking and the work that has gone into developing this model for us to consider the prevention cascade. That was a great summary. Thank you. We've got one question at the moment from Chris Manyamba to James. This says, the hypothesis that UTT may change levels of stigma, thinking aloud, what about the bidirectional relationship, stigma to UTT or stigma from UTT or bidirectional? James.
Sure. Thanks, Chris and Mitzi. So I think that's right. There's potential for multiple different interactions going on here, and we try to capture that explicitly in those three hypotheses that I outlined. So we try and I think, at least in my mind, that gets at the two directions that you're alluding to. So one is that by implementing or sort of rolling out policies and strategies to reach universal testing and then to get people on treatment quickly after they test positive, that might itself influence levels of stigma through pathways, as I mentioned, to do with kind of normalization of HIV and growing contact and sort of visibility of HIV in a non-stigmatized way. But the second hypothesis is the other way around. I think, if I'm understanding you right, that the idea that stigma could get in the machinery of how universal test and treat strategies work. Through Sinead showed that lots of the existing evidence, much of it's observational, but it's pretty. That stigma might prevent people taking up a test offer in the first place, that it might act as a barrier to them linking into care, and that's proving a really important step in the TASP experience to date, and that it might influence because of things like hiding or concealing HIV status or pills. It can get in the way of adherence too. So yes, I agree. The relationships can be bidirectional. A real strength of our study is it's not only very large, but it's also longitudinal and conducted in the context of a cluster randomized trial. So we sort of feel like we'll have a fairly unique capacity to get at which of those relationships proves to be most important. And I think that's the kind of big question. It's definitely possible that these things interact, but what's going to, whether one will trump the other or whether it will prove less important that HIV stigma for getting UTT to work, or whether that really will be a massive barrier. I think we should be able to get a handle on that with our data. So I hope that answered the question.
Thank you, James. Have we got any other questions? Can I ask you both? So there are always challenges in terms of trying to do a combined integrated approach to delivery in resource poor settings. So what does all of this mean in terms of the ongoing implementation of PrEP programs at the moment in much of East and Southern Africa?
So maybe I can have a stab at that, Mitzi. I think, as you know, there are about 50 demonstration projects across the world, really evaluating uptake and adherence to oral PrEP in a range of populations. But there's been a particular concern about the use of oral PrEP in women in Eastern and Southern Africa because of some of the data that came from the trials which showed low adherence, and that some of the explanations for that low adherence were related either to concerns about partners and partner influence over product use, but also antiretroviral stigma, so concerns about being identified as HIV positive. So if we want and I think the additional issue for women is that the adherence bar is particularly high. We know that to achieve levels of biological protection, we really need high dosing of oral PrEP amongst women. So there is a need really to consider how we can best support women, particularly to use oral TDF-FTC consistently. And I think some of the information that's come from the trials has helped us to think about how we could potentially provide support. So there are a number of projects that have been looking at different strategies around adherence. But the work that Strive has done has helped us to think about what are those things that appear to be reported commonly across all of these projects, and what evidence would we have to respond, and how, I think most importantly, can we practically integrate this within HIV programs such that it doesn't add a significant burden and can be done at scale. And so the thinking around Empower was really what are existing interventions that are already offered by the health system. And so HIV testing is already offered. And adherence clubs are an idea that has really gained traction in HIV programs based on the MSF experience of how clubs improved retention in care. And so what we looked at are ways to kind of use existing HIV prevention or HIV programming and health system interventions and adapted them then to incorporate some of the thinking around violence and stigma reduction. And I think to really the heart of your question is that whatever we do, it needs to be done in a way that's practical and scalable for the health system, or kind of could be done at a different level, kind of as a structural intervention. But the idea would be to kind of think about what are those things that are influencing the HIV program success in that particular locale, and how can you then think about adding on interventions and where might they be best directed. And we went for the health system. But in other contexts, for example, around alcohol, it may be that changes in legislation around alcohol may be kind of most influential on the HIV treatment program, and kind of it would be useful to evaluate that sort of thinking further.
I've got another question here from Bruce. Have there been enough sound interventions done for long enough and monitored properly to justify the conclusions you draw from the review of reviews? Some of these, which are not promising, have hardly been explored.
Maybe just to clarify, I think the review of reviews was really looking at, is there any evidence for gender-based violence or alcohol use or socioeconomic status or stigma influencing the treatment and or prevention cascade. And I think that there is some evidence. The quality of that evidence is restricted to observational studies or qualitative data. There are not a lot of randomized controlled trials that have tested the hypothesis, is this factor associated with potentially HIV outcome or a step in the cascade. And kind of it wasn't as if the data was universal, but there clearly does appear to be a common trend with most of the data pointing in the direction that these factors are influencing steps in the cascade. So that was point one. I think the point about interventions is that that is work that has been done separately, and there have been a number of reviews that have looked at what works to address stigma, what works to address violence. And I think in terms of the promising, that was in relation to the review done about what works for violence. And those were for low and middle income countries. The promising interventions were in fact interventions that had been evaluated in randomized controlled trials. So things like SASA, things like stepping stones, things like the IMAGE trial. And in that analysis, it's important to point out that the reviewers weren't interested in the effects on HIV, they were interested in the effects on violence. And I think those trials have demonstrated that those interventions do have effects on reducing intimate partner violence. So that is why they are listed as promising. What the work that's still to be done is really to see whether if we incorporate them within HIV programming, do they help the HIV program, and not in terms of reducing HIV incidence, because I think we all agree that there's been limited evidence for having those very distal effects, but really by intervening on violence or stigma, can we reduce the impact of those factors on the HIV program, and so allow antiretrovirals to then deal with the HIV incidence issue.
I've got a hands raised here for Ollie. So he's typed his question here. Assuming PrEP's continuing success and its increasing use in heterosexual settings, do you think it holds promise within intravenous drug use populations, not simply to address HIV, but also to normalise the issues that intravenous drug users face and address the structural marginalisation they face?
Well, that's a great question, and it's a pity that Ollie's mic is not working, because I think it would be great to hear some of your thoughts. But I think that there are two questions. The one is, what evidence do we have that PrEP might work to prevent transmission of HIV that is transmitted through injecting drug use? But we know that it is possible to prevent HIV transmission at least through heterosexual contact, and both of those routes of transmission would be important in that population. I think that there have been some concerns that in some communities that the kind of enthusiasm around PrEP might in fact undermine some of the work that's been done for these populations. So there have been concerns that PrEP might undermine the gains around needle exchange programs. I know in sex worker communities there have also been concerns that the kind of enthusiasm for PrEP might in fact undermine some of the work that's been done around kind of insisting on condom use and collective action around those activities. So I really do think that kind of decisions around PrEP need to be context and population specific. But I do think that for HIV programs it's important. So I think it's important for HIV programs really not just to go in with a new technology, but really to think about what is it that is shaping risk and what are the potential barriers to current HIV prevention programming, and to ensure that the programs are responsive, not just in terms of delivering a drug, but actually delivering a comprehensive program.
Thank you, Sinead. Maureen's typed in her question. Socioeconomic status has been mentioned as one of the structural factors affecting the 1990-90 strategy. Issues to do with addressing transport costs and unstable housing may, at the onset of the intervention, require cash support, yet the current approach to HIV prevention should be less of hardware support in order to be sustainable and scalable. How do we work around this?
So I don't mind having a go at that. I'm not sure, Maureen, thanks for the question. I'm not sure exactly what you mean by hardware support. Pull that out or to maybe type. But I suppose underlying, so you're right that the sort of narrative around socioeconomic status, its interaction with HIV risk throughout the epidemic, and then this, I think, relatively well agreed sort of notion that how socioeconomic status influences HIV risk is going to change over time, and I think will become increasingly important as we're successful in rolling out these products to some groups for the reasons I mentioned earlier. I think increasingly it will be marginalised groups who don't have access to these new technologies earliest, who have the biggest barriers to getting to the clinic in the first place. And to sustaining, whether it's PrEP or whether it's treatment for infection or PrEP prior to infection, to sustain on treatment is most challenging in those sorts of communities. So I feel like you can't ignore that in a public health approach to HIV. That's kind of, I suppose, my main sort of response to this issue. And I think there are at least a couple of approaches to. One is to sort of think about that in terms of targeting and to be able to understand where risk is, and to ensure that what we don't do is expend all the resources we have, the effort that we have the best systems always available to those who have the least barriers to accessing prevention and treatment. So one responses are sort of targeting responses, and then in some settings, I think there is a case to be made that if you could integrate these kind of programs alongside HIV programming, as Sinead suggests, I don't think we want to be entirely inventing new things, but if you can find ways to integrate responses to these real lived realities for people, when they're coming in for prevention technologies alongside the HIV program, whether that's through financial support or whether it's through more social types of interventions, I think has to be tailored for the right situation. And of course, we don't have a bottomless pit of money, but I feel like you can't ignore it. And if you can find ways of either targeting services or addressing those needs amongst people once they're in the door, then I think we need good studies that show that those approaches have benefit. And I think they will become more important rather than less over time.
Thank you very much for that, James. I know we're just out of time. I've got one more question. Well, I haven't. I've got a few others that are Strive-related people, so we will follow up with you over email. But I've got one here from Mwansa. How would you handle issues with adherence for PrEP when it is so cyclical in terms of people potentially stepping on and off it? I assume that's a question about how you monitor it and support it in programs. Yeah. Sinead, do you want to take a stab at that?
Yeah, I think it's a great question, and I think it highlights the differences between the treatment and prevention cascade. In treatment, the goal is to keep people on treatment, kind of lifelong, whereas in PrEP, it's completely reasonable to use PrEP for periods of risk and not to use PrEP at other times. So in that sense, PrEP is an option, and it's one of several prevention options, which, as James highlighted in sort of his slide on direct mechanisms, range from abstinence all the way through to use of condoms, mutual monogamy, to PrEP. And so with PrEP being a choice, I think, kind of ideally what we want is to ensure that people's risk for HIV is minimized. So we want to support women or populations, individuals who want to use PrEP to use it effectively, but also and to find strategies to support that. And we've kind of given a couple of examples. If people don't want to continue PrEP because perhaps their life circumstances have changed, as long as we can understand that they are no longer at HIV risk, I think we're comfortable. If what we find, though, is that kind of people are struggling to use PrEP and continue to be at HIV risk, that's where we need to be able to find innovative interventions that are going to enhance adherence, as well as invest in developing new technologies that perhaps kind of take away some of that adherence requirement. So I think that those are really the two options.
Thank you very much. We have run out of time. I want to thank Sinead and James for a really interesting and useful presentation. I want to thank all of the people who contributed. The questions and discussion were really useful, so thank you. Please remember that we've got another Learning Lab next month looking at development synergies.